The following podcast was recorded at the ANZICS Safety and Quality Conference 2014 Rapid Response Teams. Anna Green, Alex Psirides and Robert Herkes talk about resourcing rapid response teams throughout Australasia.
Spent quite a deal of time trying to persuade the New Zealand government that the development of a unified national early warning score system is a good idea. And I'm intrigued by the next piece of information I've got, which is that he hopes one day to be able to view every patient's vital signs on an iPad from the comfort of his bed. Thank you, Alex.
So I'm the slightly strange position of being an English person speaking about Wellington. I have a blue passport which allows me to do so with some authority. I was going to do this in a New Zealand accent, but it would be offensive for the native New Zealanders in the room, so I apologise in advance. So I seem to be one of the few people from Wellington here wanting to talk about how we do what we do. And the interesting thing for me so far has been hearing how different we are to everyone else, which seems inherently stupid because we're all doing the same thing on the same evidence base, but we all seem to be doing it differently. So just a brief introduction to who we are and where we are for the Australians and any Aucklanders in the room who don't know where Wellington is. It's the big red dot on, thank you Seaton, it's the big red dot on the map there. It's a marvellous city built on a massive fault line, which any time is probably going to go, so we'll need more than a rapid response team to rebuild the entire city. We have, the way the hospitals are dealt out in New Zealand is that generally there's sort of hope and spoke and hub models of large tertiary centres with smaller hospitals. We have a 440 inpatient beds, an 18 bed, much smaller than our Australian counterpart ICU, which is tertiary level, so we pretty much do everything. We're also slightly strange in having a children's hospital on site as well, so our rapid response team also responds to paediatric emergency calls as well. We cover 9 other hospitals. Within our district health board, we have 2 hospitals. We're the larger of the 2, and there's a smaller, slightly more elderly rehab-focused hospital that also has a rapid response system of sorts. And we have a very busy aeromedical retrieval team who travel around those 9 hospitals picking up the sicker patients to bring them to us. So we're a sort of centre of a hub of other smaller hospitals as well. So our rapid response team essentially consists of 4 people. We have an ICU registrar who is basically flying, as it were, from the floor, so they also cover the ICU. They also cover the aeromedical retrieval team, so clearly when they're flying they can't be also attending MET calls, so that defaults to the other ICU registrar, who's also supposedly covering the unit. So we don't have extra funding for more people to do this. We did this out of existing resources. In fact, when I watched the video from the first speaker, I wondered whether that was a plea for ways to fund your rapid response team. I thought that might be quite a good idea, begging with a sign outside the hospital. We have a 24/7 patient at risk nurse, which is funded within the intensive care unit. Most of them are ICU nurses, although not all of them, and they're available all the time, they're on site. We have the on-call medical registrar who loves nothing more than being called to see a paediatric patient, and we have a medical house officer as well. So all these people respond 24/7 in addition to their normal duties. The patient at risk nurse does other things as well. They follow up patients discharged from ICU, as well as accepting ward referral at nurse level as well. And I'll show you our triggered system at the moment is hierarchical. So we have a nurse entry before we get to medical entry as well, the final response being the registrar. So the actual MET call system involves those 4 people, but any of those people may have been involved in earlier stages of escalation. The MET team is usually led by the ICU registrar, depending on the politics at the time, but generally they seem to be usually the most senior person there, along with the PAR nurse. So the PAR nurse and the ICU registrars tend to make the decisions. And they report to the ICU specialist on call pretty much 24/7, which is a joy at 3 o'clock in the morning to hear about my colleagues deteriorating patients they haven't made plans on during the day. The governance comes from basically me as the ICU SMO, the only one with an interest in this, and from the PAR clinical nurse specialist as well. We work quite closely together to supervise both the medical and nursing teams, because the people who work for both of us indirectly end up working together on the ward as well. So how we got there was difficult. As with most systems, something bad had to happen before someone tried to fix it. For those of you unfamiliar, the New Zealand government set up something called the Health and Disability Commissioner, which is a government-funded organisation headed by a lawyer of medical interest who essentially writes reports on when hospitals screw up Anyone can report to the HDC, patients, healthcare workers, individuals, families of dead patients, and they basically write to them with their concerns, and they then launch semi-formal, subsequently formal investigations, and they produce reports which are publicly available, usually anonymised and available on their website. And the New Zealand media, because there's not much else to talk about, takes a great interest in whenever one of these comes out, particularly when individual hospitals are named and shamed. So our story comes from a patient who was identified in the report as patient A, who was a gentleman who was admitted acutely with shortness of breath back in September 2004. 50-year-old gentleman with a psychiatric history who was a heavy smoker, who most of the time his vital signs were required was not on the ward because he was outside having a smoke, and over essentially a day and a half to 2 days deteriorated with very little attention paid to him. And he was found dead on the morning ward round. The nurses drug around a couple of days later. This led to an internal investigation which wasn't done very well. I can say that because the HDC said the same thing and their judgment's available on their website. The patient's family subsequently complained, and the HDC then mounted what was about a year-long investigation into how this patient could have died in a tertiary level hospital when they were having vital signs taken, and they had all these investigations done. It essentially ended the clinical career of the consultant in charge of the patient. It had serious adverse effects upon the nursing staff involved, and at least one of the junior doctors involved in their care gave up medicine forever. So the implications and the fallout of this was fairly huge. What happened and what turned out to have happened was that there was a variety of investigations ordered which no one followed through on. There was x-rays taken that no one looked at until the patient was dead. There were blood tests done that no one looked at. And there was a whole series of gaps on their vital sign chart. And the logic that was put forward at the time, and to be fair to our DHB, they mounted a very misguided, spirited defence, was that he was obviously going out for a cigarette, so he must have been able to mobilise, so he can't have been that sick after all. But what the HDC did was publish probably one of the more eviscerating reports they've ever put out on the state of acute care in our hospital, and mandated essentially that we introduce early warning score based escalation criteria. What was of note was in the following few years was that most other New Zealand DHBs that read this report subsequently did it. Our hospital didn't for various reasons until it was several years down the track when several enthusiastic people, one of whom was Jenny, who opened this morning, was involved in getting some money together to actually fund a service from within the intensive care. So our system was very, very much reactive to a public naming and shaming as opposed to proactive from all the evidence you've been hearing about earlier today, which in retrospect was not the best way to go about it. So that's how we got to where we are, thanks to, unfortunately, a man who had to die. So what we now have is much better, obviously. We have a standardised vital sign chart that's across all patient ward areas over the 2 sites I've talked about. We have an early warning score that's based on vital signs, and we have a staged pathway, which is based on either aggregate individually deranged signs or concern or single base parameters for severe deviation where the medical emergency team can be called. We have different variants to cope with our different patient needs. We have an adult early warning score. We have 5 variants of the paediatric early warning score, and the obstetric team now have MEOWS, which is the modified early obstetric warning system, which I think they stole from the UK. Every acronym of EWS you can think of has been devised. We are also talking about family-triggered escalation. So if the family think their patient is deteriorating or the patient themselves thinks they're deteriorating, they can bypass the ward doctor or nurse who tells them everything's fine and call directly to the patient at risk team to get someone else to come along and have a look at them. That is, how shall I say, controversial amongst some of my colleagues, as you can probably imagine. That hopefully will happen soon, but that's still being talked about, and we have a large number of people to be convinced that this is a good idea. We have a paper-based chart system. The age of technology, at least in Wellington, is a long way coming, and obviously that has a variety of flaws that go with it. So this is our early warning score matrix. It's based heavily on the UK National Early Warning Score because that still remains the only early warning score for which there's any actually evidence base to show that it works in terms of detecting deterioration. We've modified it to include MET parameters because I believe the Australasian model of single parameter based calling is its greatest strength because it makes people who don't know much about sick people easy to spot them. It also means you don't have to add up numbers to get to a score. If you can just look at a single parameter, work out it's over the line, then you just dial the number and someone comes and makes it all better for you. We've just in the process of changing from an old system to the new system. This will be the new system. We've dropped urine output, mainly because no one measured it and no one could measure it well. Everyone was confused about what you do if they've got a catheter or if they just go to the toilet and don't tell you how much they've peed, and I can see the problem with that. So it's interesting to hear that some people are using it. We've gone towards oxygen saturation and supplemental O2 as a binary yes or no, and clearly that weights, you would assume the people who are hypoxic are on oxygen, or that may not always be the case. Apparently people on epidurals get it randomly. I've never worked out why. If you're on epidural you need oxygen, but there you go, I'm not an anaesthetist. Similarly, you can see our deranged vital signs are relatively generous. Heart rate less than 35 was modified mainly at the request of our cardiologists, because there's so many fit, healthy people in Wellington with heart rates of 36 who don't need met calls. But also it reflects the judicious use of beta blockers amongst the population probably. So this is our escalation pathway. It's based, as I said, on either single parameters or based on an escalating collection of numbers being added together. So we start off with anyone in the yellow zone or any vital signs in that area with a score of 1 to 3. The obvious answer is to keep measuring the observations. Consider doing it more frequently. Talk to someone more senior in your ward who might be able to help you. If you have any vital sign in the orange zone or a score of 4 to 6, then the house officer must review the patients within 60 minutes. And also they're advised to discuss with the nurse in charge and inform the patient at risk nurse. So this is the first level of external intervention. The PAR nurse comes along, looks at the patient and decides what to do. The next zone is the red zone. Any vital sign in that zone or early warning scores between 7 and 9. The registrar, that's the home registrar, not the ICU registrar, must review the patient within 20 minutes. They must inform the PAR nurse, the house officer and the nurse in charge they have a patient who's continuing to deteriorate. And then finally we have the blue zone, which is a mandatory met call. All of these are supposed to be mandatory, and the instructions on the chart tells you to escalate as things get worse. So as you get worse and you move through those parameters, if you don't have a house officer review within an hour, you go to the next point, which is called a registrar within 20 minutes. Although we don't know for sure, I'm guessing our compliance with this is about 5%. We know our compliance with met calls is pretty good, but certainly the escalation criteria is pretty poor, as you'd expect when you introduce a mandatory system. People do still do what they want to do. We collect a variety of data. We have hospital switchboard records, we have a patient at risk nurse database, we have reportable events registry, and we have met case report forms. All of this just generates more paper that piles up on my desk because we don't have anyone in our system other than myself and the CNS repar who processes any of this. The one interesting thing we do have that we decided after much debate a while ago is that every cardiac arrest in our hospital is a mandatory reportable event, and they're all reviewed externally. So every person who has CPR in our hospital, including ICU, theatres, even on occasion ED, is reviewed externally by a group of people who decided whether this was appropriate, whether we were assaulting a dying person, or whether there was marked deterioration that had been going on that no one had done anything about. So that goes to the clinical response committee, and we look at all these people. That was, again, difficult to persuade my colleagues that this was beneficial, but we found it useful. So this is what the effect of our data has been. It's the same graph as everyone else, which is always interesting to see. As our met call rate has increased, our cardiac arrest rate has dropped right off, to the point now that cardiac arrests in our hospital are fairly rare, I'm glad to say. They still happen, but when they happen, we look at them. And the only reason we've been able to make them all reportable events is because they're getting increasingly rarer. These are our rates per 1,000 admissions. On an annual basis, we've reported the same 30% reduction in cardiac arrests. We moved hospital between 2010 and 2011. We got a massive new shiny built one that cost us a huge sum of money, which is why the numbers don't track completely. But year on year, you can see these are absolute numbers, and clearly 2014 is only half a year because we're just in July. But our cardiac arrests have gone from 67 in 2011 down to 15 so far, and they're tracking on a 30% reduction year by year, which is encouraging. The effect of this has been that the gaps between met calls and cardiac arrests has changed. In 2009, we went 69 hours before met calls. Until we introduced a mandatory system, we now have 3 a day. For cardiac arrests, we went 98 hours. We're now 292 hours. So they're becoming increasingly rare events. We have the same solar-powered hospital effect. During daytime, there's a lot of people around, so the light powers them to detect deterioration. Overnight, everyone goes to sleep, so we don't see them. That's the same as everywhere else. That's cardiac arrests in red and met calls in green. The interesting thing we've noticed is that I also collect hospital mortality for all the wards where met calls occur, and we're showing in the last year now a drop-off in hospital mortality. someone cynically pointed out they probably just built a massive hospice across the road, so everyone's going across the road to die. But I would like to think this is a Met call effect. It may be, and I know Daryl's got data that shows a similar effect. But our in-hospital mortality now has dropped to 1.5%, having previously been hovering around 2%, so maybe a 25%. I've not run any stats on that, so that's probably just random fluctuation. In terms of things we do well, I strongly believe single parameter Met calling is fantastic. It allows anyone to identify what sick people look like. If they mark the cross on the chart in that zone, they have to dial 777 in our hospital. They have no choice. And I audit all the ones that don't get done. And only when you get submitted to ICU after a Met call, we count up the number of times they missed before they end up in ICU. We've now managed to successfully establish this across multiple areas, and it's part of the daily workflow. And we've got a fairly good multidisciplinary team with good medical and nursing governance. The downside is we have an ability to alter the score weighting, which sometimes is good, sometimes is bad, because it allows people to continue to deteriorate whilst the doctor just changes the goalposts. It's paper-based, which makes it difficult because people have to add it all up. The escalation, as everywhere else, is reliant on ward nurses doing what the protocol says they should and relies on them speaking up against a system that may be trying to suppress them. We have a large number of registrars who rotate through, as does everywhere else, and keeping them up to speed with why we do what we do is very difficult. We still have a strange system where the switchboard staff have to differentiate between cardiac arrest and Met call, despite pleas that we modify to a single number. You dial a number, but the switchboard then asks you, is it Met or cardiac arrest? So I have a horrendous transcription of a conversation that then followed, where someone said, is it a Met call or cardiac arrest? Oh, hang on, I'll go and find out. Click. 2 minutes later, it comes back, oh no, it was a cardiac arrest. Great, can we put out the cardiac arrest call? We're trying to fix that and hopefully will. We have a Met led by junior staff. They are registrars. We don't have a consultant presence for Met calls. And by increasing those numbers so much, we may have actually broken the hospital, because our registrars and the medical registrars now are running around attending to Met calls, putting out fires for other people. The hope that we would have more proactive decision-making by our colleagues is yet to appear. I mentioned this was mentioned in the introduction. This is something I've been ranting on about for years. We have 20 DHBs in New Zealand. We're fairly small. We have, most of the intensivists know each other, and we should be fairly good at standardising this. It's a kind of a no-brainer. We should be able to have a New Zealand early warning score. Unfortunately, there seems to be a huge lack of central governance sorting this out, and it's kind of been left to several of us to try and do this on a DHB by DHB basis. Most hospitals' DHBs are numbers that were made up on the back of a piece of paper. We've written a paper that shows there's a huge variation nationally in New Zealand, and we would hope eventually we can try and come up with a system that follows the same parameters. So if your early warning score is 4 in Dunedin, it's the same as having an early warning score as 4 in Auckland. Auckland's very special, but they don't have abnormal physiology as far as I'm aware. So everyone should have the same mortality and morbidity attached to them based on an early warning score. Anyway, it's something I'll keep ranting on about. We'll hopefully have 4 DHBs aligned with our scoring system in probably 6 months to a year, and then that only leaves 16 to conquer. We will get there eventually. Whoops. Sorry, that's the final slide. Thank you very much.
For more podcasts from ANZICS, go to anzics.com.au.